Postgraduates. So today's topic will be on the PUO or FUO, which is one of the toughest topics in our clinical medicine. Even today, in spite of the lot of the advancements in our diagnostics or our radiology, etc., still nearly 10 to 15% of the cases, we are not able to come to a reasonable diagnosis. See, if you see the humanity, it has the three great enemies: fever, famine, and wars. Of these, the greatest and the most terrible is the fever. So you can imagine now the lot of the war is going on between Israel and Palestine, etc. And I think that fever is much more dangerous than those wars. So that clearly shows the importance of the fever to deal in our day-to-day practice. And in fact, it is one of the commonest symptoms we often see in the outpatient as well as the inpatients. And fortunately, one side of the coin is most of the fevers, they subside by themselves. So by the time you want to address the etiology of the fevers usually most of the fever they subside. I mean, we forget. On the other hand, and some of the fevers very, very troublesome. So in spite of our routine investigations or extra investigations or radiological investigations or your FNACs or biopsies, etc. So still the diagnosis is not known, and most of the people they are going to die much early or with living with a lot of the morbidities if the diagnosis is not come to a reasonable conclusion. So it's not my word, it's the William Osler, a great fellow in our clinical medicine. He said that the greatest and the most terrible is the fever among the fever, famine, and the wars. See, one time the Benjamin, in his prologue to his famous book Chest X-rays, chest röntgenology, says that all of us have a tendency to make a diagnosis on the basis of the past experience with the similar shadows. But remember, many dissimilar conditions cast the similar shadows. The same thing happens in our fevers also. It looks like the common malaria, or looks like your enteric fever, or your dengue, or your meningitis, but the diagnosis is totally different. It could be a neoplasm, or it could be a connective tissue disorders, or something else. So many dissimilar conditions may cause fevers which appear to be the similar. So that is our beauty of the medicine, especially in fevers. So you should have a very, very clear-cut knowledge in 360 degrees of the medicine. Otherwise, you are going to miss some of these conditions. So the Pyrexia is from the Greek origin. Pyre means the fire. And febrile is from the Latin word febris, meaning the fever. So both the Pyrexia and the febrile conditions, we consider that Pyrexia is fire and febrile is the fever. So the fever is nothing but the elevation of the body temperature above the normal circadian variation. That is very important. See, the morning it is about 37 degrees centigrade, so 98.6. By evening, it is about 37.6 degrees, 99.6 degrees Fahrenheit. So the normal circadian variation would be 1 degree of the Fahrenheit. So some of our patients, so they thought that while their temperature is 99 or 99.5 at about 5 p.m. or 6 p.m., so they consider that still they are running the fever. So this is a circadian rhythm is common in all of us. So you all know that the rectal temperature is higher than the oral temperature, and the oral temperature is higher than the axilla temperature. In menstruating women, the early morning temperature is subnormal in the 2 weeks preceding the ovulation. So these are all the patterns of the fevers. A continuous fever, the temperature remains elevated above the normal throughout the day without touching the baseline, and fluctuations does not exceed 1 degree. So that is the continuous fever. So always above your baseline, but not more than 1 degrees variation. So that is the continuous fever, like your lobar pneumonia, etc. And this is the remittent fever. Here the fever persists throughout the day. The temperature fluctuations exceeds 1 degree Fahrenheit, but without touching the baseline. So in both the continuous fever and the remittent fever, the temperature will be above the baseline. But the fluctuation is not more than the 1 degrees in the continuous fever, but here more than the 1 degree in the remittent fever. So the morning will be 104, and afternoon it will be 103, and evening it will be the 100, never touches the normal, and fluctuations also more than the 1 degree centigrade, that is the remittent fever. Here the typical causes, the typhus fever, sepsis, tuberculosis, especially the acute phase, and the rheumatic fever. So the intermittent fever, the fever presents during the day, but the temperature touches the baseline at some time or other. So most of the time the patient is the afebrile, but sometimes the fever will be there, that is the intermittent fever. You have the 3 types of the intermittent fevers: quotidian, tertian, and the quartan. So the quotidian is a fever present every day and touches the baseline daily, whereas the tertian on alternate days. Quartan, the fever present on every 3rd day. So these are the fevers of fever, quotidian fever, tertian or quartan of the intermittent fever, continuous fever, and the remittent fever. Okay. Here the causes the malaria, urinary tract infections, pleuritis, etc. So these are all the different patterns of the fever. In continuous fever, the fluctuation will not be more than 1 degree. In remittent fever, never touches the baseline more than the 1 degree. Quartan fever on every day. Tertian fever, 2nd day, and quotidian fever event. So quartan fever is on alternate days. So the relapsing fevers, the febrile episodes are separated by the normal temperature for more than the 1 day. Here the brucellosis, rat bite fevers, etc. Drug fever, that is the one subset because of the frequent usage of your steroid therapy or your immunosuppressive therapy, etc. So nowadays we are seeing a lot of the drug fevers also. It is a prolonged fever and may belong to any febrile pattern. There is a relative brad. Usually in fevers you expect the tachycardia, whereas in the drug fevers there will be the bradycardia. Almost all drugs can produce the fever except the digoxin. So some common drugs: sulfonamides, methyl dopa, penicillamines, iodides, anticonvulsants, etc. So a lot of articles will be there on the drug fever. A chronic salicylate intoxication can cause increased heat production by uncoupling oxidative phosphorylation. So a lot of the drugs will cause the fevers. What is the commonest cause of the PUO? Is it a common disease presenting in an atypical way, or a rare disease presenting in an atypical way? Common disease presenting typically, or rare disease presenting the typically? So PUO means, you should always remember, all the common diseases presenting in an atypical forms. So the atypical presentation of a common disease is much more common than the common presentation of a atypical disease. So the commonest cause of the PUO is common diseases presenting atypically. So as a postgraduate, so you should know all the common diseases, both the typical presentations and the atypical presentations. So you have to spend a lot of the time. So far now we have discussed the malaria, we have discussed the typhoid, we have discussed the filaria, we discussed the urinary tract infections, we discussed pneumonias, we discussed tuberculosis, we discussed COVID, we discussed HIV. See, these are all the common diseases we often see in our day-to-day practice. So you should know both the common as well as the uncommon presentation of these common diseases. Then you will not miss the diagnosis of the PUOs. See, there will be some terminology, some epidemiology, etiology, diagnostics and therapeutic options, and finally outcomes of this PUOs. Let us see, this is the old definition and the new definition. The old definition was given in somewhere in 1961 by Petersdorf and Beeson, I think. So Petersdorf and the Beeson, these two people, they first given the criteria for the PUO in 1961. So they have set the 3 points there. One is fever more than 38.3 degrees centigrade, that is about 101 degrees Fahrenheit on several occasions. The duration more than the 3 weeks, and then after 1 week of the intensive inpatient evaluation. So that is their old definition. Peterstaff and Beeson, given in 1961. Okay. And then after the 30 years, exactly in 1991, another two people, I think Durack and Street. Yes. Durack and the Street in 1991, they have given the new definition. Here the old definition, inpatient for 1 week. But in the new definition, they have given the 3 outpatient visits also. In spite of the 3 outpatient visits, or in spite of the 3 days of your intensive inpatient evaluation. Again, the 3 weeks and the 101 temperature is both the points are there in both the old definition and the new definition. In the new definition, what is new is they have also included the outpatient. So 3 outpatient visits are not the 1 week of the intensive inpatient management. 3 days of the intensive inpatient evaluation. If you are not able to come to a reasonable diagnosis, so that you can consider it as a PUO. So that is our new definition. So again, they have divided into the 4 groups. Now the 5th group is also added. The classical PUO, the nosocomial PUO, and the neutropenic PUO, and HIV PUO. And now the transplant PUO also added. So these are the different classes of the PUOs. Yeah, it's a Durack and the Street. That's a new definition. So the classical PUO, the temperature more than 38.3 degrees, 101 Fahrenheit, 3 OP visits or 3 days of in-hospital evaluation, 1 week of intelligent and invasive investigation on the ambulatory basis, temperature remains undiagnosed more than the 3 weeks of the duration. So here most of the times you have to remember the 3, more than 3 weeks, 3 days outpatient, 3 days inpatient. Okay, that is our classical PUO. Nosocomial, again the temperature more than 101, patient hospitalized for more than 24 hours, but no fever nor in incubation at the time of the admission. The fever remains undiagnosed after evaluation for at least 3 days. Neutropenic, here the neutrophil count is less than 500. After evaluation of at least 3 days, the fever remains undiagnosed. HIV associated, so they will have the HIV infection confirmed by your TRIDOT or your Western blot, etc. Here the duration of more than the 4 weeks for the outpatient and more than the 3 days for the inpatients. Okay. So if you see the epidemiology and the etiology, India infections are more common, nearly 47 to 52% in different papers. South India, North India, etc. Somewhere between 47 to 54% of the infections. Whereas in the Western population, it is non-infectious inflammatory diseases like your connective tissue disorders, etc. So in the Western world, the infections are only 17%, 14 to 17%. Whereas in India, around 50%. So now the malignancies are increasing. You all know that lymphomas, leukemias, rectal carcinoma, prostatic carcinoma, thyroid carcinoma, gastrointestinal carcinoma, hepatocellular carcinoma, pancreatic carcinoma, breast carcinoma. So these are all the carcinomas, malignant melanomas. So these are all more liable to cause PUOs. Collagen vascular diseases, we have discussed every disease of the collagen vascular diseases in our past lectures, starting from your rheumatoid arthritis or lupus, systemic sclerosis, dermatomyositis, Still's disease, Behçet's disease, Sjogren's disease. So all these diseases are potential candidates to cause the PUOs. And still the miscellaneous and undiagnosed are there still about 10 to 15% of the cases. Still we don't know the exact cause of the fever in that individuals. So in India, infections around the 50%. Now the malignancies are gaining up and also the collagen vascular diseases are also there. Whereas in the Western world, more of the collagen vascular diseases and the malignancies. So infection is the most frequent in 30-70% undiagnosed PUO, in 2005 to 10% undiagnosed PUOs. Now the lot of the advancements are there in our PCR technology. ELISAs, your CT scan, your MRI, PET scan, FNAC, biopsies. So all these things will definitely help us to clinch the tissue diagnosis and the diagnose, and some of the people will have the localizing symptoms or the signs also for the proper diagnosis. That is the reason nowadays we are able to come to a reasonable diagnosis in about 80 to 85% of the PUOs, which was not there in the 30s and the 50s or the 60s, where only 25 to 50% they used it to come to a reasonable diagnosis because of the lack of these sophisticated investigations. Modify the spectrum of the PUO causing the diseases, serology, HIV. Now it's very, very high in our society. And luckily, the virulence of the HIV is reduced nowadays. We are not seeing the new cases, but a lot of the old cases with AIDS and etc. we are seeing today. And of course, lupus, we are very familiar. Young females, hair loss, photosensitivity, oral ulcers. Definitely, you are dealing at arthralgia, polyarthralgia, and then serogitis, maybe the pleuritis, pleural effusion, or ascites, or pericardial effusions, maybe neuropsychiatric manifestations, maybe the lupus nephritis. So definitely, we can come to a reasonable diagnosis of lupus with your ANA positivity, double standard ANA positivity, UN RNP positivity. So definitely, it could be a case of the SLE. Nowadays, the diagnosis of the connective tissue disorders are not at all difficult, provided if you have a high index of suspicion. So if you suspect the connective tissue disorders, order for the ANA profile. So definitely in another 1 or 2 days, so the profile will be in your hand, and definitely you can come to a reasonable diagnosis whether this fellow is having RA or the lupus or systemic sclerosis or others. Imaging technologies and abscesses, solid tumors. So with the high technology, we will have the CT and MRIs and also the ultrasound abdomen. So you can come to a reasonable diagnosis of your hepatic abscesses or pyogenic abscesses, splenic abscesses, or retroperitoneal abscesses. Psoas abscess is so common. Scrotal abscesses. In the same way, PUO masses. So these are all possible to diagnose with these investigations. And solid tumors, such as sarcomas. So they also will cause PUOs. So the fever lasting more than the 1 hour, infections, malignancies. See, the majority of the diseases remaining after an initial negative workup. So the initial investigations are the bedside investigations. Routinely, you do the complete blood picture, complete urine examination, liver profile, renal profile, electrolytes, okay, and chest X-ray, ultrasound abdomen. So all these is still the negative workup for the neoplasms, collagen vascular diseases, increasing the tuberculosis, especially extrapulmonary tuberculosis, drug addiction, maybe thrombophlebitis, deep vein thrombosis, pulmonary embolisms, etc. Elderly with endocarditis, subacute endocarditis. So that could be the one of the reason in the elderly individuals. So your musical murmurs, your Roth spots in the fundus, okay, Johnway lesions, etc. HIV with or without infections are the malignancies. So I told you all so many malignancies, they're all more associated with your fevers. Implanted prosthetic devices. So these are also causes. So especially the knee replacements, okay, hip replacements, shoulder replacements. So these are secondary infections. They're very common nowadays. And travel, new exposure. Now the world has become a small village. So what is common in New Zealand and definitely will be in New Delhi in another 1 day or 2 days. So now the air travel is very high. So that is the reason. Now the no disease is particular in what particularly region, especially in India. Because you go anywhere in the world, the Indians are there. And all our Indians will visit their places on so many occasions because of the highest number of the festivals in India. No other country will have the number of the festivals what we have it. So the children infection is the most frequent, your Epstein-Barr virus or cytomegalovirus, etc. Elderly neoplasms, you have to think of the neoplasms in elderly PUOs, and connective disorders, especially in the young females between 25 to 45 or the 50 years of the age group. So in elderly individuals, these two are very common: giant cell arthritis and polymyalgia rheumatica. So in giant cell arthritis, so these people will have the ESR more than the 100. You have a throbbing headache, and the temporal artery will be the palpable, and there may be the biopsy of the temporal artery is also needed to diagnose this giant cell arthritis or temporal arthritis. Polymyalgia rheumatica, that is also very common in elderly individuals. Again, here the ESR will be more than 100, and the people will have the arthralgia, arthritis, asthenia, fever, loss of appetite, and also the sarcopenia, etc. So these two one should be considered when you are dealing a case of the PUO in elderly individuals. See, malaria, yes, India is the place, and especially now Rajahmundry and Kakinada, we see a lot of the malaria because of the lot of agency individuals. Brucella, yes, when they are exposed to the animals, so the brucellosis is very common, especially Saudi and Gulf area. Kala Azar, yes, in Bihar, West Bengal, they are so common. Leprosy, all over in India, still it is there. Typhoid, so common in India, Pakistan, etc. Histoplasmosis, west coast of the USA. Tuberculosis, all over the world. India is the capital. 50% of the tuberculosis cases are there in India. Liver abscess, both amoebic abscess and the pyogenic abscess. And of course, HIV turned into the AIDS. So PLWH and AIDS are very common in our society. So these are all the diseases very commonly associated with your PUOs. So I told you that neutropenia, where the WBC count will be less than 500 cells. So the fever without the source, mostly the bacteremia. Fungal infections, the fever lasts for more than 7 days. Fever usually co-founding an underlying disease, drugs, blood products, allograft resection, etc. So coming to our Indian perspective, as I told you that infectious diseases are most common, number one killer in cause for your PUOs. And among the infectious diseases, more than the 50% are tuberculosis. So tuberculosis has been found to be the most common cause of PUO in India. And among the tuberculosis, it's not the pulmonary tuberculosis, mostly the extrapulmonary tuberculosis and miliary tuberculosis, they are very common. Residents of the Bihar and Jharkhand present with the pancytopenia and a massive splenomegaly suggested the visceral leishmaniosis. People from Nagaland and Manipur, those infected with HIV, present with the anemia. So they are mostly the fungal infections, they are common. And Karnataka, North India, Kashmir, with exposure to the animals, present with the hepatosplenomegaly and multiple joint involvement, arthralgias, it is brucellosis. Northeast Indians present with oral ulcers, skin ulcers, adrenal enlargement, so it is histoplasmosis. So these are the points towards your localizing symptoms or the localizing signs towards a diagnosis. Okay. So oral ulcers, skin ulcers, adrenal enlargement, it's your histoplasmosis, disseminated histoplasmosis. So a good number of the patients with the scrub typhus. So now the scrub typhus is, we are seeing scrub typhus last 4 or 5 years. Okay. Have been detected in several studies from Tamil Nadu, Rajasthan and also from AP. So PUO varies based on the etiology of the fever, age group, geography, environmental exposure, and your immune status or HIV status. In developing countries, infectious etiology of PUO is the most prevalent. In developed countries, is most likely to the non-infectious inflammatory diseases like connective tissue disorders or malignancies. So these are all the autoimmune diseases or connective tissue disorders to the tune of about 20 to 25%. Adult Still's disease, polymyalgia rheumatica, temporal arthritis, rheumatoid arthritis, inflammatory bowel disease like your ulcerative colitis or Crohn's disease, Reiter syndrome, your oral ulcers, etc. Lupus and vasculitis, maybe small vessel vasculitis, medium vessel vasculitis, large vessel vasculitis, your Goodpasture syndrome, etc. Takay's arthritis. So when working up the differential diagnosis of the PUO, it is important to remember that the cause is more likely a subtle or atypical manifestation of the common disease. As I told you, mostly the tuberculosis, malaria, typhoid, HIV. So tuberculosis, especially extrapulmonary tuberculosis, abdominal abscesses, so different abdominal abscesses. So maybe because of your cholangitis or cholecystitis or pancreatic abscesses because of the chronic pancreatitis, pelvic abscesses. Okay, so these are very common. Dental abscesses, endocarditis, sinusitis, of course, HIV, prostatitis, osteomyelitis. So these are, one should not forget all these conditions as a cause of your PUO. So you have to check the oral cavity thoroughly to rule out the dental abscesses. So you have to see both the PR and the PV also in some of the cases to avoid, to rule out the pelvic abscesses or gluteal abscesses, perianal abscesses, etc. So these are very, very important. So one has to look after all these conditions to rule out the exact cause of your come to the neoplasms. So the lot of the neoplasms, already told you the leukemias and the lymphomas and metastatic cancers, so secondaries, renal cell carcinoma, carcinoma colon, hepatocellular carcinoma, myelodysplastic syndromes. So nowadays we are seeing more of the myelodysplastic syndromes, especially with the pancytopenia, elderly individuals, etc. So they present with the low backache and fever, or diffuse pains and the fever. So pancreatic carcinoma, sarcomas, solid tumors. So this is also very important. As a good physician, so everyone thinks of the infections or connective disorders or neoplasms, okay. But we are interested in these conditions also. So the 10% of the conditions, maybe a drug-induced fever. Already told you a lot of the drugs. Factitious fever, deep vein thrombosis, sarcoidosis, you will have hyaluronopathy, your ACE levels will be increased. Hepatitis, maybe the alcoholic or the granulomatous or tuberculosis or the lupus, complications of the cirrhosis. So these could be some of the miscellaneous causes for the PUOs. So still 10 to 15% of the cases remain undiagnosed despite the extensive investigations. Okay. So that is the reason now the medicine has become the both art as well as the science. So earlier days, medicine means only art, eliciting the good history, examining the patient. It is almost a art. Now you have to add the science also. That means your diagnosis come to a reasonable diagnosis, the tissue diagnosis or evidence-based medicine. So for the evidence-based medicine, you need a scientific approach. So when you are dealing a case of the PUO, so after taking in the history and the clinical examination, you have to rule out lot of the conditions and come to a reasonable conclusion. So then act accordingly. So don't do all the tests in a particular patient of the PUO. Suppose if the patient is having respiratory symptoms, so then you think of the CT chest or some bronchoscopy, etc. When the patient is having the abdominal pain, a chronic abdominal pain and the PUO, then the ultrasound abdomen or the CT abdomen, etc. So the history and the clinical examinations will tell you how to deal the patients with these different investigations. But still, about the 10% of the cases remain undiagnosed despite the extensive investigations. 75% of these cases, the fever resolves spontaneously. So that is the good point of the care. So in spite of the intensive investigations, you are not come to a reasonable diagnosis, but luckily 75% of the people, the fever subsides spontaneously. They are happy, you are also happy. But in the remainder, other signs and symptoms make the diagnosis very clear. So this is the psychogenic factors like habitual hyperthermia seen in young females, temperature 99 to 100 degrees. So especially in the nurses or in the internists. So the habitual hyperthermia. Okay. Afebrile FUO. Patient always complains of the feverishness, but the temperature recorded is always less than the 38.3 degrees. So that is afebrile PUO. Hysterical PUO. The patient thinks and believes that he is always having the fever. So three major causes: infections, abscesses, especially occult abscesses, intracellular organisms, and intravascular bacterial endocarditis. So we discussed everything about the tuberculosis maybe 4 or 5 classes ago. But here one word about the disseminated tuberculosis, the single most common infection in most PUO series except in the children and the elderly, especially the young adults. Usually extrapulmonary or the miliary tuberculosis or occurs in the lungs and significant pre-existing lung disease. Pulmonary TB in AIDS is often subtle, normal chest X-rays in 15 to 30%. So even though the patient's X-ray is the normal, you are supposed to go for the CT chest to rule out the internal lesions. Your manto will be the positive in less than 50% of the TBs with the PUO. So the manto positivity doesn't mean that the patient is having an active infection of the tuberculosis. Manto positive means either active infection or latent infection or exposure to the tubercle. So it's an allergic reaction to your tubercular protein. So not all people will have the active infection once the PPD is positive. Diagnosis often requires lymph node biopsy, liver biopsy or bone marrow biopsy in some cases. So lymph node, suppose when the fellow is having the cervical lymphadenopathy, so anterior cervical lymphadenopathy or posterior cervical lymphadenopathy, some people will have the supraclavicular lymphadenopathy. So when they have the supraclavicular lymphadenopathy, so the most commonly it is because of the malignancies, maybe malignancy of the stomach or malignancy of the gut. So then go for the FNAC and the diagnosis clinched or the biopsy of the lymph node. So most of the times no cervical lymphadenopathy, it may be a non-specific lymphadenitis or granulomatous lymphadenitis, mostly COX. So treat with the ATT. Bone marrow biopsy is also required in some of the cases of the PUOs. Sputum is positive in only 25% of the cases in PUOs. So when the sputum is positive, that is your golden diagnosis. So definitely, so the patient is having tuberculosis, and also you can send the sputum for your resistance tests also. So whether it is a MDR or XTR, so accordingly you can treat with the anti-tuberculous drugs, whether your regular anti-tuberculous drugs or second line of the anti-tuberculous drugs. But still the sputum is positive in only 25% of the cases. Abscesses are very common, very tricky also. So usually look at it in the abdomen or in the pelvis, secondary to the appendicitis or the diverticulitis. Pyogenic liver abscess usually follow the biliary tract or abdominal suppuration. Amoebic liver abscess similar to the pyogenic, but amoebic serology is positive in more than the 95% of the cases. So usually amoebic liver abscess are maybe usually 1 or 2 or the 3, and there will be the septae between them. But where the pyogenic liver abscesses are multiple in both the lobes of the liver. Splenic abscess is usually secondary to the hematogenous seeding. So splenic abscess is also common in sepsis, in septicemias and bacteremias. Perinephric or the renal abscess is usually secondary to the urinary tract infection. So ascending urinary tract infections. So whether E. coli or the Proteus or Klebsiella, etc. So definitely there will be the ascending UTIs, and these people will present it with the pyelonephritis and sometimes pyoceles. So entire kidney will be filled with the pus only. So all these things can be clinched with your ultrasound abdomen or CT abdomen. Now the bacterial endocarditis. So earlier we used to see a lot of the endocarditis because of the high prevalence of your rheumatic heart disease. So nowadays we are not seeing much of the endocarditis because of the less and less cases of rheumatic heart disease right now. So culture remains negative in 5% of the patients. Here you have to send the blood for the 3 times blood cultures. 3 times in all the PUO cases, whereas the urine culture 1 time. So that means in the first time blood cultures, you may not yield the positive result. In the second time, the third time. So like your AFB for 3 times, in the same way the sputum for AFB for 3 days, in the same way the blood culture should be sent for 3 bottles. Culture negative is likely with the following organisms: Coxella burnetii, no growth. HASEC group, incubation period, incubate the blood for 7 to 21 days. What do you mean by HASEC? Hemophilus, maybe C. Campylobacter, E. So C. As a short notes, you may get the HASEC group. So this is the name given to the different bacteria. HACEK. Okay. Then the Brucella, Legionella, Mycoplasma, Chlamydia, fungal, usually the sterile. So sterile pyuria, mostly the fungal. Peripheral signs may not be detected. Right side endocarditis, they lack the murmurs, self-antibiotics, and the growth will be the negative there. So vegetations, nowadays we can easily diagnose the endocarditis with your 3D echoes and the 2D echoes. So we can know the vegetations on your mitral valve or tricuspid valve or aortic valve. And some people, they may require the transesophageal echo also. Okay. In that way, you can know the vegetations much better in the tricuspid valves and the aortic valves. In lymphomas, fever is a presenting feature. A leukemia, multiple myeloma, fever means the infection there. Renal cell carcinoma, sometimes. Hepatocellular carcinoma, secondary metastasis of the liver also cause fever. In lymphoma, fever is a well-recognized manifestation. Pell-Epstein phenomenon is rare here. Production of the cytokines is the source of the fever. Fever is a negative prognostic factor. Renal cell carcinoma, 20% they present with the fever. Microscopic hematuria will be seen in your renal cell carcinoma. So again, these two can be detected with your ultrasound, CT abdomen or CT chest, and then biopsy is very much needed here. Maybe ultrasound guided biopsy or CT guided biopsies. Wilms tumor in the children, the peak incidence is in 2 to 3 years of the age group. Abdominal mass, but fever can be a presentation. So the Wilms tumor people in the children, they present with the fever, and obviously the pediatricians will diagnose the Wilms tumor thanks to the radiologist. Solid tumor, fever is rare except the secondary metastasis to the liver. Ductal obstruction or the perforation like cholangiocarcinoma or ampulla carcinoma of the pancreas, head of the pancreas. Lung carcinoma with obstruction of the pneumonias. So these are all the fevers present in the solid tumors. So you need to recognize the syndrome, otherwise no diagnosis of your collagen vascular diseases. So there are the different diseases already we discussed. Still's disease, adult onset. Age between 16 to 33 years. With a negative rheumatoid factor and the ANES. Fever is high and spiking with the temperature up to 41.6 degrees centigrade and hectic fever. Intermittent or the remittent. Peaks typically at the night. So they seek the medical attention within the 2 weeks. A distinctive enhancement macular or the maculopapular rash is typically present during the course of the illness. So here the clinching point here in the Still's disease and adult onset is your rash. So you know all the causes of the fever with the rash. Maybe your dengue fever or some other viral fevers or your scarlet fevers or your Zika fevers. So these fevers with the rash here, again the Still's disease with adult onset Still's disease also will have a maculopapular rash. See the myalgias, arthritis may appear after weeks and months. There will be the leukocytosis, hepatosplenomegaly and lymphadenopathy in Still's disease. So in arthralgia, fever, hepatosplenomegaly, lymphadenopathy and leukocytosis. Very high serum ferritin levels. So temporal arthritis, very serious condition. If not diagnosed early, very difficult to establish the etiology of the fever if you don't have the index of the suspicion. Typically Caucasian, but it occurs in the others also. Fever and malaise may be the only manifestation. Headache is the most common. And if you diagnose it, if you start using the steroids, excellent response. Jaw claudication, visual loss with your temporal arthritis. If there is an unexplained fever, anemia and high ESR in elderly without an obvious cause, unilateral or bilateral, short versus the long segment biopsy is needed of your temporal artery and the treat for long duration. Treat for at least 2 years with your steroid therapy or sometimes no immunosuppressors also. Polymyalgia rheumatica can cause fever, arthralgia, myalgia. As I told you, here also it is very high. Muscle complaints, symmetrical pain and the stiffness, typically worse at AM morning times and affects the lumbar spine and the large proximal muscles. Polyarthritis nodosa will cause mononeuritis multiplex, vaginous granulomatosis, mixed cryoglobulinemia. So they will have a pulmonary symptoms, sometimes hemoptysis, etc. Pulmonary emboli, nowadays more common following your COVID era. Now 50% of the febrile with the pulmonary emboli. Patient typically has the predisposing factors, cancer, the recent immobility or the COVID. Hematoma in a closed space. So when it causes the PUO, usually arise from the hemorrhage in the retroperitoneal space or within the wall of an aneurysm or the dissection of the thoracic or the abdominal aorta. Aneurysms, very, very common. Now the Veteran hunter, Rajinikanth, he was admitted recently in Chennai with abdominal aneurysm. So transthoracic aneurysm. Okay. He was operated. Now doing well. So aneurysms, aortic aneurysms are very common. Hyperthyroidism. So occasionally cause the PUO. Most frequently diagnosed clinically, they will have the tachycardia. You all know the hyperthyroidism symptomatology. So the PU is also one of that. So loss of unintentional weight loss. Your tremors, tachycardia, resting tachycardia. So definitely hypothyroidism. Now it is a spotter when the fellow is presented with severe hyperthyroidism or hypothyroidism. So for physicians, it's a spotter. No local neck pain or the typically enlarged non-tender thyroids. Adrenal insufficiency. So sometimes we see it. Recently I have seen one patient with PUO where the adrenal send it for the adrenal normally somewhere between 20 to 30. She got only 1.2. So that's severe adrenal insufficiency and started on steroid therapy, responded very well and discharged. So the adrenal insufficiency in some individuals. So the rare but potentially fatal but imminently treatable cause of the PUOs. Consider the treatment if there is nausea, vomiting, weight loss, hypotension, hypokalemia and hyperkalemia. She got hypotension and hypokalemia and hyponatremia. She is not having the hyperkalemia, my patient. So when I send it for the adrenal values, the serum cortisol, so they are very, very, very low. So treated with the steroids and responded very well. The familial Mediterranean fever, Arabic fever. So a lot of people are, Indians are working in Arab countries. Okay, especially Godavari districts and Karimnagar. Class 4 employees. Recurrent fever, arthritis pain out of proportion to the signs, polycyrogitis, leukocytosis, affect mainly Arabs, not always hereditary. So there is a familial Mediterranean fever, also called as FMF. FMF, familial Mediterranean fever. Alcoholic hepatitis, often unsuspected, patient denies. Fever is usually low grade. Jaundice and hepatomegaly. AST will be more when compared to ALT. So SGPT will be more than the SGOT. Leukocytosis is often there. If you don't think about it in the right time and with the right patient, then you will be troubled with and will work a lot in order to get the etiology. So most of the people know, they say no to the alcoholism history. So the factitious fever is the febrile PUO. 9% of the cases in one study. So very high number. This is a false fever. Thermometer manipulation using external heat or substitute the thermometer to escape from the studies, to escape from the work. Okay. Men use this way. Physicians are rare for this disorder, increasing somewhat in the elderly. Genuine fever, self-induced. Administration of the pyrogenic substances. bacterial suspensions. Generally, young women with connection to the healthcare, often the nurses. Both are Hindus or both are Muslims? Or one Hindu, one Muslim? So we should not look in those lines. Both are human beings. Okay, both are human. Unfortunately, most of our people, even our educated people, for everything they say Hinduism, Islamism, etc. So finally, it is the humanism. Humanism that matters a lot. Okay. So the diagnostic approach, a careful history, I told you, and physical examination, repeated physical examination. So don't be happy with the examination on today. So if you are in a doubt, even after 2 days or 3 days, again from the top to the bottom, you have to examine the patient. Sometimes in the naked way also. So because you are going to miss some scrotal abscesses or your other things in the private areas. So you are definitely you are going to miss it. So in all cases, the PUO, you have to examine top to the bottom. Verify the presence of the fever. Series of 347 patients for prolonged fever. 35% were ultimately no fever or factitious fever. Duration of the fever is important. Travel history. So this is a very important. See the travel, 1 to 10 days. It could be malaria, plague, dengue, salmonella. 10 to 21 days. Malaria, typhoid, brucella, FPA. Weeks are the months. So could be kala azar, amoebiasis, HIV, hepatitis. So as a good physician, you should remember these things. So depending on your travel history. So travel to an area known to be endemic for the certain diseases. So a lot of the people know the Canada people or other people, most of the people they visit to Rajahmundry or to the Kakinada most of the times. So if there happens to be a fever, if they get the fever, then as a good physician, you are supposed to examine them. So you have to think all these things. When the travel history is 1 to 10 days, so these are the diseases. 10 to 21 days, these are the diseases. And weeks and the months. So kala azar, amoebiasis, HIV and the hepatitis. Okay. So this is the very, very important. Localizing symptoms may indicate the source of the fever. So backache. So especially examine the not only your lumbar spine and the sacral spine, please see the thoracic spine also. That is the place where port spine is very common. So the tuberculosis of the spine is more common in the thoracic spine rather than your lumbar spine or the sacral spine. So TB spondylitis. Bone metastasis again. So in the thoracic spines and the cervical spines, lumbar spines, etc. Headache. Chronic meningitis. So it is, I have taken one class on meningitis. Not taken? Okay. So that also, yes, meningitis we have discussed. So again in chronic meningitis we will have headache, chronic headache. Right upper quadrant pain. So maybe the liver abscess, right side, maybe cholangitis, cholecystitis, etc. Left upper quadrant pain. So splenic abscess. Okay. Oral and the genital ulcers, Behçet's disease, jaw claudication, temporal arteritis, subtle changes in the behavior. So maybe the meningitis, maybe the Cox meningitis, etc. or the fungal meningitis, etc. So these are the localizing symptoms. So backache, headache, right upper abdominal pain, left upper abdominal pain, oral and genital ulcers, jaw claudication, and behavioral changes. So come to a reasonable diagnosis accordingly. So the family history. Scrutinize it for the possible infectious or hereditary disorders because your tuberculosis, so maybe the runs in the family because it's a contagious disease. Okay. And what is FMF? Familial Mediterranean fever, maybe the hereditary also. Past medical conditions, lymphomas. So past history of the lymphoma. So there may be a recurrence of the lymphoma. So for rheumatic fever, maybe recurrent rheumatic fever, Still's disease, Behçet's disease. Okay. Exposure to the sexual partner. So acute HIV. Illicit drug abuse. So infective endocarditis, hepatitis B or C and HIV. So these are the very, very important. Okay. So the clinical approach. So a comprehensive history, a meticulous physical examination, Appropriate laboratory testing, not all the laboratory tests in a single patient, appropriate laboratory testings, and finally some management points. So fever of unknown origin, complete the physical examination, exclude the drug fever and stop unnecessary drugs. Specific clinical findings, lymph nodes are positive, so get the FNAC at the biopsy and then treat accordingly. Some abscesses, where are they? Scrotal abscesses, prostatic abscesses, intramuscular abscess, so your injection abscesses. Okay, pus and blood cultures, tissue biopsy and the cultures. Yashkar, so definitely your scrub typhus. IgM ELISA for Shushugamushi. What is that? Yes. Skin lesions, biopsy and the culture, especially fungal and the bacterial skin lesions. Anemia, so the bone marrow aspirates and the tryptophan biopsies, bone marrow biopsies with the bacterial and the fungal cultures. Stool occult blood with relevant scopes. So if these findings are there, so you are having a localizing points towards the particular disease and then treat accordingly. If these localizing findings are not there, then you order for your LFT, blood cultures 3 times, malarial parasite, ultrasound abdomen, HIV serology, bone marrows, inflammatory markers, etc. They are the positive, so appropriate follow-up and the diagnosis testing. And further extensive tests like CT abdomen, CT thorax, Brucella serology, echo examination, colonoscopies with biopsies, especially for the Western population, there the carcinoma colon is very, very common. So always once in a year, they go for the colonoscopies. Liver biopsy, LP, so especially in our India, so definitely LP is very much needed in our PUO cases because to rule out your chronic meningitis or Cox meningitis or fungal meningitis, etc. ACE levels, so to rule out your sarcoidosis, more increased levels of the ACE in sarcoidosis. Dental evaluation, OBG evaluation, ENT evaluation, your mastoiditis or the CSOM, etc. So in that way you have to do this. Finally, PET scan. So comprehensive history, a recent visit to an endemic area like agency, malaria could be, recent exposure to the STD, inject illicit drugs like hepatitis B or C and HIV. Occupational history, exposure to the birds, psittacosis, or to the animals, brucellosis or toxoplasmosis. A history of exposure to the unpasteurized dairy milk, okay, may suggest brucellosis, Q fever, Yersinia, enterocolitica. Exposure to the birds, so chlamydia psittaci. Exposure to the cats, toxoplasmosis or cat scratch disease. HIV or gonorrhea in travelers and sexual encounters without the barrier precautions. Epstein-Barr virus in daycare centers as it spreads very easily. See the beautiful history. If you take all these points, then you will come to a reasonable diagnosis. So history is very much important in most of our clinical cases. Physical examination, skin rash, skin nodules, so your rheumatoid nodules, etc. Conjunctival petechiae, in a dengue fever you will have it. Clubbing, okay, in bronchiectasis, etc. Splinter hemorrhages, infective endocarditis, etc. Migratory asymmetrical arthritis, so in rheumatic fever. Jaundice, edema, alopecia in chronic hepatitis. Tender lymph nodes, tongue coating, boils, furuncles, so pyogenic infections or sepsis. Non-pruritic skin rash, coupled with alopecia, oral ulcers, arthritis, hepatosplenomegaly. Young females, so lupus. Presence of bronchial breathing, infiltrative rales or the pleural rub, mostly the pulmonary tuberculosis. Enlarged liver, spleen, ascites, abdominal mass, so tuberculous abdomen, paraaortic lymph nodes, so tuberculosis or lymphomas. Malignant lesions, carcinoma head of the pancreas. You can go for the markers there, maybe 19.9, I think. Genitourinary examination for UTI or the TO mass in the females, especially tuberculosis. Tuberculosis mass, TO mass are very common in our Indian females. Meningeal irritation, so neck stiffness, etc. Rudinsky's sign, so mostly meningitis. Rock spots, endocarditis, choroid tubercles in miliary tuberculosis or lesions of the cytomegaloviral retinitis. Perrectum examination, perianal abscess, inflammatory bowel diseases like ulcerative colitis. So looking for the key physical side, diagnostically yield 60% in the children, 50% repeat. Document the fever, analyzing the pattern, whether it's a tertian or quartan, Epstein fevers, pulse and temperature dissociation. So you expect the tachycardia and fever, but in the relative bradycardia, so typhoid and the brucellosis. So these are the different fevers. Lymphadenopathy is a very common in our people. So cervical area, localized one. So it could be tuberculosis is the number one. Then the lymphomas or infectious mononucleosis, or maybe non-specific lymphadenitis or bacterial lymphadenitis. Supraclavicular, higher risk of the malignancy, mostly the gut malignancy. Here an index case, 32-year-old woman with 1 month history of the right post neck mass with fever and malaise. Received 10 days antibiotics but no response. An examination, maybe T3, I think, maybe T4, 38.4, very much elevated. Several lymph nodes in the neck. They are non-tender and rubbery. Lab, WBC, neutropenia, ES are elevated. Paratracheal lymph nodes. All other lab results, the tuberculin test is the negative. So what is the next? Here the finding point is neck mass, right neck mass with fever and malaise, elevated T3, leukopenia. Intact capsule, so that lymph node biopsy. Yeah, she had the lymph nodes, no? So intact capsule, discrete area of the necrosis, histocytes are present, no plasma neutrophil cells, no follicular hyperplasia, and no granulomas. So this is Kuruchi's disease, I think. Histiocytic necrotizing lymphadenitis. Benign, self-limiting. Okay. Young Asian females. Cervical lymph nodes with the fever. There will be leukopenia in 50%. Leukocytosis in 5%. Diagnosis is by typical histopathology. Because in the histopathology, no plasma cells, no neutrophil cells, no follicular hyperplasia, no granulomas. So that is a benign disease. Examine for the lymphadenopathy, paraumbilical hernias, abdomen or the pelvic neoplasms. Generalized lymphadenopathy, look for ectomegaly and splenomegaly. Indicate the significant systemic diseases like lymphomas, leukemias, and infectious mononucleosis. Painful glands, painless glands, mostly the malignancy. Painful glands, mostly the infective etiology. So inflammatory process or the suppuration. Hemorrhage into the necrotic center of a malignant node also causes the painful gland. Consistency, hard node, stony hard in cancers and metastasis. Firm and rubbery, lymphomas. Soft and fluctuant, infections and tuberculosis. Matting, tuberculosis, sarcoid, metastatic carcinoma and lymphoma. So matting not always in the tuberculosis only. So matting may be benign and the malignant matting. Benign matting either sarcoidosis or tuberculosis, and malignant matting carcinomas and lymphomas. Skin is very, very important. As I told you, you can request one of your dermatology friends to take up a class on skin and general medicine. Very big topic. Very nice topic, very interesting topic. So the rash, lupus, all types of the rashes is described. I told you everything about the lupus. Still's disease, evanescent erythematous rash over the trunk. Infectious mononucleosis, you have the macular rash. Infective endocarditis, Janeway's lesions, rot spots, etc. Typhoid fever, rose spots over the abdomen. Osler's nodes, they are the painful nodules on the pads of the toes and the fingers. Infective endocarditis. So you have to examine the skin for all the rashes, these nodes, etc. See these nodes, embolic nodes, Janeway's lesions, conjunctival petechiae in a patient with bacterial endocarditis. Oral ulcers. So maybe aphthous ulcers sometimes. The most common oral ulcer is the aphthous ulcers. They are painful, but the painless ulcers are dangerous. So there could be a lupus Behçet's disease. So in Behçet's, they will have also genital ulcers along with the oral ulcers. In a lupus, oral ulcers and alopecia, arthralgia, photosensitivity, etc. So examine for the arthritis in these conditions. Examine for fundus, so rot spots, etc. Choroidoretinitis, very typical in CMV retinitis. Physical examination, new or the changing murmurs. Temporal artery, nodular and weakly pulsatile. Sinus tenderness in chronic sinusitis. Tender tooth, so your abscesses in the tooth abscesses, etc. Thyroid enlargement of the tenderness, maybe hyperthyroidism or Hashimoto's thyroiditis. Cough tenderness, so deep vein thrombosis, etc. Nails, splinter hemorrhages, clubbing. See, you have to see everything in the clinical examination in the case of the PUO. So hair, your eyes, nose, ear, mouth, teeth, okay, your neck, your thyroid, lymph nodes, cervical lymph nodes, supraclavicular lymph nodes, chest, abdomen, scrotum, etc. Okay, and even the limbs, toes also. So these are all very, very important. Examine everything. See how you are supposed to get some clues or some findings by examining these things, and then your diagnosis will be easy. And you are going to a localized diagnosis. If you don't know everything, then you are bound to write almost all the battery of the investigations. So stage 1 screening, lot of the investigations we write it. On the stage 2 screening, what are all the investigations I told you from almost all the investigations? They are supposed to do it in some cases. So CT, chest, pelvis, ECG, autoantibody screen, that is your ANA profiles, etc. Protein electrophoresis, so rule out your multiple myeloma, etc. Serum ferritin levels, that will be very, very high, more than the 200 in some cases. Coagulation workup, so your pulmonary embolia, deep vein thrombosis, etc. PSA, that is a prostatic specific antigen to rule out the prostatitis or prostatic malignancies, and other markers like FEA for your hepatitis, CA 19.9 for your carcinoma, pancreas. So chest X-rays, MRI, brain, etc. So investigations must be individualized based on the most probable suspected diagnosis. DD will depend upon the geographical area, age, and the comorbid conditions. In general, non-invasive investigation should be done first before going for the invasive investigations. So a complete blood count ESR is very helpful. So in the blood count, so not only your hemoglobin and the total counts, so you have to assess whether the polymorphs are there, how the lymphocytes, how the eosinophils, how the monocytes, and then your MCV, MCHC, etc. And most important is your PCV, packet cell volume, or your hematocrit, and the platelet counts. So these indices, so these are also very important in your CPP examination. Again, the CPP examination is a must for all the physicians. So don't think only that hemoglobin and the TC are important. Everything in the complete blood picture is important. That gives you a clue towards the probable diagnosis in your PUO cases. In the same way, complete urine examination also. Not only your proteins and the urine sugar, you see whether the nitrates are positive or not, bilirubin is positive or not, blood is positive or not, or pus cells, and then the specific gravity. Okay, so and cash, so they can help you in identifying whether the patient is in a UTI, whether the patient is having the proteinuria or when the patient is in a CKD, or when the patient is in acute nephritis, okay, or in uncontrolled diabetes, or in the ketone bodies are positive, urine or 4 plus, etc., and early DKA. So all these things you can know it in complete urine examination. So complete blood picture, complete urine examination, and of course all other investigations. So as a physician, you are supposed to see these investigations and you have to act accordingly, and then see how these investigations are abnormal, and they all put these abnormal investigations in a one particular one diagnosis, and then the diagnosis will be very easy and the treatment will be easy. Peripheral smear is very important. Midstream urine culture is sterile. PCR may be suggested for the PCR. Now the PCR is a very, very important investigation. So PCR your typhoid, PCR for your dengue, PCR for your tuberculosis, okay, PCR for your brucellosis. Now almost all the investigations you get the PCR can be done within 1 to 2 hours. You will get the report. Not only the report, you can tuberculosis you will get the resistance also. Whether the rifampicin resistance or INH resistance also you will get it in a matter of just 1 to 2 hours. Fungal etiology may be revealed very slowly. Nowadays, the fungal infections are also very common because of the uncontrolled diabetes and elderly individuals and comorbidities. People are on steroid therapy. People are on immunosuppressive drugs. They are more prone for the fungal infections. Blood culture should be done routinely in all the fevers pertaining for more than a week. Many a time, repeated blood cultures may have to be done to isolate the organisms. So, has suggested for the infective endocarditis. PCR is very valuable in detecting the nuclear components of infecting organisms early in the disease. Specific and reliable, but false positive results may also occur. You see, all these investigations, we have the false positives and the false negatives. So definitely by taking a good history and the clinical examination, so we can point towards the particular diagnosis here. CPNAT, yes, to detect the latent tuberculosis. Manto, yes, positive. Possibility of the tuberculosis infection past or latent or active. Not all the people positive for the tuberculosis manto positivity doesn't mean that they are having an active infection. Maybe the latent infection also. You need not treat with the ATT. Wait for that. Suppose if you want to start with the biologicals like your rituximab or infliximab, etc., then you can treat it. Otherwise, not needed to treat. It may be misleadingly negative in miliary tuberculosis. Manto will be the negative in miliary tuberculosis and also in immunocompromised individuals. So in the HIV positivity or miliary tuberculosis, even though the active tuberculosis is there, your manto test may be the negative. So here the false negative. Rise in serum uric acid level. Now the uric acid levels is no more a marker for your gouty arthritis, but also a marker for your vasculopathy. So the more the uric acid, the more the chances of having the ischemic heart disease and coronary artery diseases. So the serum uric acid levels may suggest the rapid cell turnover, especially the malignancies, like the lymphomas. Rise in the serum alkaline phosphatase, so the liver cell involvement. Serum CPK levels, so dermatomyositis. Here you may need the skin biopsy or the muscle biopsy to confirm the diagnosis of dermatomyositis. Detection of the specific antibodies against the infective organisms. So Vidal, Salmonella, ASO titers for streptococcal, so malaria for malaria, VDRL, TPHA for syphilis, HIV 1 and the 2, HIV, leptospiral antibodies, leptospirosis. So hepatitis C, cytomegalovirus and all these for their respective viral diseases. Rheumatoid factor, anti-CCP for rheumatoid arthritis. ANA, double standard ENA and UNRNP for SLE. ANCA, anti-neutrophil cytoplasmic antibody for vasculitis. C-ANCA for venous granulomatosis. Blind application leads to excessive tests, excessive number of the tests. So that is very important. Okay. So the blind application, when you are very poor in your evaluation of the PUO, so there will be excessive number of the tests. Anemia if present suggests a serious underlying disease, but unfortunately 80 to 90% of Indians are anemic. Okay. So here the anemia means the hemoglobin will be 4 or 5 or 6. And the hemoglobin is 10 or 11. Most of Indians will have 10 or 11 hemoglobin. Okay. Leukocytosis is the bands, occult bacterial infections. Lymphocytosis and atypical lymphocyte. So infectious mononucleosis or tuberculosis. Leukopenia and lymphopenia, advanced HIV. And also in most viral diseases, you will have the leukopenia and the lymphopenia. Leukoerythroblastic anemia, disseminated tuberculosis. So thrombocytopenia. So not only in the malaria and the leukemia, your dengue fevers and other viral fevers, they also have thrombocytopenia. More than the malaria and the leukemia, dengue and viral fevers. Peripheral blood, malaria or filaria. So urine analysis, urine culture is very, very important to rule out your urinary tract infections and ascending infections. ESR, if elevated, significant inflammatory process, greatest use in the establishing a serious underlying disease, is a very high. Tuberculosis, multiple myeloma, temporal arteritis. 58% malignancies, lymphomas and myelomas. 25% infection, endocarditis. CRP, so that is another acute infection reactant, closely associated with the inflammatory process, not invariable components of the febrile response, usually does not go up with the viral infection. ESR and CRP, this is very much elevated in the bacterial infections, neoplasms, immunological mediated inflammatory states like your connective tissue disorders and tissue infarction. So these are the acute phase reactants, acute phase proteins. Fibrinogen, proteins are increased here, ferritin increase, plasminogen, protein S, ceruloplasmin. So these also as a physician you should note these points. See, acute phase proteins. Proteins decrease the albumin, transferrin and alpha. So most of our people, they will be hypoalbuminemia. Okay, in PUO cases. On the other hand, if you send the blood for the fibrinogen or protein S, so they will be elevated. Okay. So these tests we are going to do it. Anti-nuclear antibodies, rheumatoid factor, etc. Cultures, I told you, obtain more than the 3 blood cultures from separate venipuncture over 24-hour period. If you are suspecting infective endocarditis prior to the antimicrobial use, always get the cultures prior to your antibiotic therapy. Otherwise, you are going to miss the positivity in your cultures. Incubate the blood for 4 weeks to detect the presence of the CV and brucellosis. You send the blood for the culture and sensitivity and start empirical management. The report will come at a later time and accordingly you can change your antibiotics. Sputum for tuberculosis is very, very important. Tissue diagnosis. Any normal sterile CSF, urine or pleural or peritoneal fluids. Imaging. So big thanks to our radiology population. They are doing a tremendous help for all of our physicians for a proper diagnosis, not only in PUOs, in most of the conditions, especially our biochemistry people, pathology people, microbiology people, radiology people, who should be very much thankful from their day in and day out, every day. Without their help, no. So we are going to get the very, 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 very bad diagnoses. So X-ray, the most time honored, almost universally available, relatively cheap and non-invasive imaging modality, pneumonias and tuberculosis, etc. Paranasal sciences, bones, joints and others. Skeletal scurvy, multiple myeloma. See, whenever you deal a case of the PUOs, just don't send the fellow for the chest X-ray alone. On the day 1, write chest X-ray, write the X-ray of your nasal sinuses, etc. or the X-rays of your thoracic spine to do the port spines, etc. So when the fellow is having any pains in the short, small joints of the hands, etc., your X-rays of the hands, etc. So in a single shot, if you get an X-ray of the chest, X-ray of the sinuses, X-ray of the thoracic spine, X-ray of the hands, you can rule out to so many diseases. Okay. Ultrasound. Detect the organomegaly, free fluid in the pleural, peritoneal, pericardial. In the same way, ultrasound abdomen. So don't be stopped there only. Ultrasound abdomen including the pelvis. In the same way, ultrasound of the neck also to rule out any unidentified or undetected cervical lymphadenopathy or any thyroidomegaly Okay, so that also can be done in ultrasound of the neck. So ultrasound of the neck, ultrasound of the abdomen, including the pelvis, and ultrasound of the scrotal area is also very, very important in all the PUO cases. So you can detect the hepatic tumors, abscess, biliary disease, almost all the diseases in the abdomen you can detect with these investigations. Echo is very, very important. Sometimes no, even when the 2D echo is the normal, so don't be happy with the 2D echo alone. Still you are in a doubt of having the infective endocarditis. Send again for your transesophageal echocardiography. So to rule out other vegetations in the walls area. So gallium scan, technetium scan, acute infection of the bones and the tissues. Indium labeled leukocytes to detect the occult septic focus. Gallium scan to detect the infection of the malignancies. PET scan. It is almost one of the important investigations in all the PUO cases, especially FDG PET. That is fluorodeoxyglucose. So fluorodeoxyglucose PET scan to detect the metabolically active malignant lesions. So still when you are in a doubt in cases of the PUO, we send it for the PET scan to know whether there are any metabolically active lesions in there or not. Sometimes we are going to get a few positive points there and we can diagnose the case. See transthoracic and transesophageal echo to detect the bacterial endocarditis. See the case of the multiple myeloma. A female, 52 years, recurrent spells of the fever, pain in the back, ribs, left arm, multiple myeloma. Most of the times, when the 52-year-old female complaining of the pain in the back, backache, or the rib pains, or the arm pains, so you are not paying a lot of attention. Maybe because of simple osteoarthritis. Okay. But when she says that a fever along with these pains, so always think something else. So it could be multiple myeloma. Multiple myeloma. See obstructive hydrocephalus. Male 22 years, recurrent fever, obstructive hydrocephalus. Shunt operation done, improved symptomatically, ATT given, fever spells cleared and improved. See the first picture, hydrocephalus. Second picture, postoperatively, hydrocephalus gone. So this is the tuberculosis meningitis. So you should know everything about the tuberculosis meningitis as a physician. It's a very, very big disease, very, very common in our society. Tuberculosis meningitis. See the intraceptor tuberculomas. B-cell lymphoma. 75-year-old male with recurrent fever and night sweats. PET scan whole body. Intestinal tuberculosis. 28 male present with recurrent spells of the fever. Mild splenomegaly. Received 3 courses of anti-malarials. After 6 months interval, complaining of the fever and abdominal pain, constipation for 3 days. Plain X-ray, multiple fluid levels, subacute intestinal obstruction. Operated, intestinal bit sent for biopsy, suggestive of tuberculosis. That is very common in our routine practice. So the surgeons know, they do the laparotomy and the surgical evaluation for your intestinal obstructions, etc. And then send the specimen for the histopathological examination, turns out to be Cox etiology. Then they keep starting on the ATT. Renal tuberculosis, 30-year-old female, recurrent spells of the fever, intermittent, pain in the loin, weight loss, night sweats, dysuria, kept on antibiotics and urinary antiseptics for 4 weeks. Your azithromycin, nitrofurantoin, the citralca, okay, etc. CBP revealed normal, except for lymphocyte predominance. Plain X-ray, ultrasound abdomen, normal. She complained of oliguria. Then the CT abdomen revealed urinary sludge at the left pelviureteric junction. Then the sludge was taken and sent for the culture, and the PCR revealed positive for multi-drug tuberculosis, miliary tuberculosis. And ATT was given and patient became normal gradually. See, her urine exam is the normal, ultrasound abdomen is normal, X-ray abdomen is normal, but finally CT abdomen shows some sludge there, and then that was sent for the histopathological examination, turns out to be the Cox etiology. See, and every point is very important in our population. So Crohn's disease and ulcerative colitis, now they are gaining up. No more a disease of the Western population. It is also common in our Indian population because of the pizzas and other things. 26-year-old male presented with recurrent abdominal pain, fever, weight loss, 3 months duration with diarrhea and vomitings. Biopsy report suggests to inflammatory bowel disease, moderate to the severe Crohn's disease. See the gallium scan here, osteomyelitis. See the beautiful aspergillosis, pulmonary aspergillosis, right upper lobe. Here the adrenal tuberculosis. See oral candidiasis, osteomyelitis, echocardiograph, your infective endocarditis, vegetations, clinical examination, ocular nodes, Genevous lesions, Roth spots, cytomegalovirus, retinitis and tuberculous choroiditis, liver abscesses, right lobe of the liver, a beautiful circumscribed abscess. In the same way, the lung abscess in the right lower lung, PCV in AIDS patients, pyelonephritis. See the kidney there, disordered size, shape. So pyelonephritis, pyonephrosis. Here no more a functioning kidney here. So you have to sacrifice that kidney. So nephrectomy is needed here. Otherwise, the patient will go into sepsis and septic shock and multi-organ failure. See the pulmonary embolism, cerebral abscess. So these are all the causes for your PUO. See the sarcoidosis, hilar adenopathy. See the pulmonary tuberculosis, both the upper lobes. MRI with MR spectroscopy. So these are all the imaging studies. CT scan and CT chest, mediastinal mass, could be tuberculosis, lymphoma, sarcoidosis, dorsal spine, spondylitis and displaced disease. CT scan abdomen, very effective to visualize all types of the abscesses. MRI, spleen, lymph node and the brain. See, all these investigations are very, very useful and very helpful and very much available in our areas. So serologies, when you are in a doubt for brucella, cytomegalovirus, HIV testing, anti-tuberculosis therapy, anti-nuclear factors. Scannings, thallium scan, scopes, bronchoscopes, bronchoalveolar lavage, for culture of the organism and cytology for the pulmonary disorders, malignant, bacterial, fungal, parasitic infections. So 3 months back, I have seen one patient, female aged about 55 years. She is a diabetic, hypertensive, and presented with right pleural effusion. Okay, and pleural aspiration was done and sent it for the cells analysis, ADA, India ink preparation, and malignant cells. Malignant cells negative, India ink preparation negative, ADA positive, lymphocytes were there, and protein was about 4.5, and your serum protein and pleural protein ratio is more than 0.5, and then we started on ATT. Okay, patient was not responded. And even after the 1 month of intensive ATT therapy and pleural effusion increase in its size, almost 4 times aspirated, each time about 500 to 750 ml. And almost all the investigations were done. And finally, we sent it for the bronchoscopy, and that is done to be a bronchoalveolar lavage showed bronchogenic carcinoma. Okay. So clinically, it looks like a straw-colored pleural fluid. ADA positive, lymphocytosis, protein is there, no malignant cells. So finally, it turns to be a bronchogenic carcinoma. Okay, so that is very, very important. So we have to respect all the investigations. When you are in doubt, so please advise the proper investigations. So in that case, the echo was the normal and all other investigations were the normal. So we lost her. She died. Malignant bacterial, fungal and parasitic infections. So the biopsies, bone marrow aspiration, already I told you. Lymph node biopsies, especially tuberculosis, lymphomas and secondaries. Muscle biopsy, dermatomyositis, polymyositis, ultrasound guided biopsies. Fungal infections are very common in immunocompromised and other investigations. Laparoscopy, biopsy. So management, unless the patient is acutely ill, no specific therapy is started, because non-specific therapy is ineffective and mostly delays the diagnostic process. Okay, in a case of the PUO, so please spare a lot of the time to the patient. So before coming to a reasonable diagnosis, don't start any specific treatments. Okay, just give the paracetamol, just maintain the vitals, and then do all the investigation, battery of the investigations. So whenever you are reasonably concluded or diagnosed, then treat that particular disease. So unnecessarily don't start with as if the patient is ceftriaxone deficiency. So once admitted, don't start with the monosef IV, mono injection Pantoside or injection Joffar or injection Polybayan, etc. Okay, only Dolo, only paracetamol, SOS, and good temperature chart. An exception is the neutropenic PUO, for which delay could lead to the severe complications. So respect the total count. When the total count is less than 500, so that is a neutropenic PUO. So act accordingly. Otherwise, these people will go into big sepsis. Hence, after blood samples for cultures are taken, aggressively treated with higher antibiotics. In addition to your granulocyte colony stimulating factor, filgrastim, that is also available. Sarcoidosis, 20 to 40 years of the age group, occurs in non-smokers, highly varying clinically. Non-caseating granulomas in one or more organ systems, almost a closed DD for your tuberculosis. In tuberculosis, you have the caseating granulomas. Here it's a non-caseating granulomas. And there will be irreversible fibrosis and honeycombing of the lungs with a mediastinal lymphadenopathy. Musculoskeletal system involvement. Lymphomas, very common. Polymyalgia rheumatica. So coming to the therapeutic trials. These are best avoided whenever possible. So there is no role of the therapeutic trial in this era of evidence-based medicine. So try to know the exact cause of that fever. So then only you can treat with this particular drugs. But this therapeutic trial now, when it's 30 years back or 40 years back, when there is no investigations, so usually they used to give some malarial therapeutic trial or enteric fever therapeutic trial or tuberculosis therapeutic trial, etc. If instituted, the drug should be specific for the situation. Aspirin in a possible case of juvenile rheumatoid arthritis. ATT for 3 to 4 weeks in suspected occult tuberculosis. Antibiotics in a patient with suspected endocarditis awaiting the culture report. Limitation and risk of empirical therapeutic trials. Rarely specific. Underlying disease may remit spontaneously, false impression of the success. Disease may respond partially, and this may lead to a delay in the specific diagnosis. Side effects of the drugs can be misleading. So that is the reason these are the limitations of your therapeutic trials. What is the best therapy for PUO patient? To hold the therapeutic trials in the early stage, except in patient who is very sick to wait, like your neutropenic PUOs, or all tests have failed to uncover the etiology, especially in infective endocarditis. When you are thinking that still the cultures are the negative, etc., then you can try with the therapeutic trials. Antimicrobial trials for your endocarditis, pelvic inflammatory diseases, typhoid fevers. Empiric drug, tuberculosis, culture negative endocarditis, vasculitis, temporal, pulmonary emboli. See, these are the troublesome diseases or very grave diseases, like especially your biliary tuberculosis or disseminated tuberculosis. Empirical drug for suspected TB, presence of granuloma on biopsy before the culture report. Elderly or immunocompromised patient with a positive TB skin test deteriorating the clinical condition. So usually, in immunocompromised patient, you expect a negative Mantoux test, but a positive Mantoux test in an immunocompromised individual suggests that very severe pulmonary tuberculosis in them. Then you can go for that. No drug for stable patient without any suggestive features laboratory results. So the diagnosis depends on the cause of the fever, nature, diagnostic delay has adverse effects on intra-abdominal infection, miliary tuberculosis. So here you should come to a reasonable diagnosis very fast. Otherwise, see, undiagnosed PUO patients generally have the favorable outcome. So that is one good point for us. Undiagnosed PUO generally have a favorable outcome. So credit goes to you, even though you don't diagnose the cause for the PUO because it has a favorable outcome. See, recover in 4 weeks time, about 80% of the population. Recover in 2 years time, 2 years, 90%. Requires NASIAs or the steroids in 10% of the individuals. Mortality rate 5 years after the discharge is about 3%. So these are all the possible reasons for your PUO. Uncommon manifestations of the common disease. Minimal or absent localizing features. Drug fever or drug resistance. New or unfamiliar diseases. Your Nipah virus or Zika virus, etc. So if you see that case, no, it's very difficult to diagnose on the day 1 and the day 2. So definitely take some more time. So these are the new diseases or unfamiliar diseases. Diseases of the interventions. Multiple diseases in a patient. Partial and inappropriate treatment. Limitations of the investigations. And immunocompromised status. So these are all the possible reasons for your PUO. Very important reasons. So diagnostic clues often are not readily apparent on the physical examination. Repeated examinations may be essential. This is a very important take-home point for all of you. In all the PUOs, repeated examinations are very, very important. Examine the patient again and again. Careful attention to the skin, mucous membranes, lymphatic systems, as well as abdominal palpation of the masses and organomegaly is very much needed. The physician's choice of imaging should be guided by findings from a thorough history and the physical examination. A cost-effective, individualized approach is essential to the evaluation of these patients, and without a thoughtful and focused investigation, inappropriate tests might be performed. So thank you very much for your patient hearing.